Okay, so I'm gonna get started. It's 12:03. We have a lot of participants, so I'm really excited. Thank you everyone for joining us today. My name is Jessica Oliveira. I am a physician assistant by training, but I also recently received my doctorate in medical science. And I am the director of Saving Mothers in Guatemala. And I also work at Florida International University's Herbert Wortham College of Medicine as a physician assistant in a program called Neighborhood Help. So I'm excited to be here today to introduce you to the rest of our Guatemala team and the amazing work these women have been doing for the past 10 years. So today you're going to hear from Eleanor Lawrence. She has her master's in public health and is our on-ground program director. In a sense, she does a little bit of everything. We also have Concepcion Mendoza, who is a licensed practical nurse. She works for the Guatemalan Ministry of Health as a labor nurse in the local clinic in our community. And she also serves as the director of the School of Power in Santiago Atitlan. She is a midwife by calling and has always been a big member in educating her community. She's a leader in the community, and we are very happy that she's been a part of Saving Mothers since the beginning. So, Nazanin, you can go to the next slide. So this is just an introduction to our staff, so you know how many women are working with us in Guatemala. So you'll see that these are all our educators. They were actually our first graduate class in 2014, and these women have shown leadership in their community and the desire to continue to work in maternal health and really reduce maternal mortality. So they've been a part of Saving Mother Sisterhood since 2010, most of these. Some of the younger ones came to us recently, and this is our beautiful team. Okay, so first, we thought it'd be good to give you a little bit background on Guatemala. So Guatemala is the most populated country in Central America. However, 45 to 60% of the population is indigenous. It also has the largest economy in Central America, but the second highest level of poverty. So, I mean, I think this slide right here just gives you a general overview of the disparities that must exist in Guatemala, especially among the indigenous communities, which is what we're really going to talk about today, is maternal health in indigenous Guatemala. So this is a country where half its population is indigenous, and then about 60% of the population lives below the poverty line. These rates are much higher in indigenous groups, primarily those that really live in the rural highlands of Western Guatemala. A little bit about healthcare in Guatemala. I'm just going to give you some general topics, but I really would like Concepcion to give us maybe a little bit insight, being that she has worked for the Ministry of Health for over 15 years, and she also has grown up in this community. So healthcare in Guatemala is very difficult, not just if you live in a city or if you live in a rural area. And Guatemala right now used to have the highest, I'm so sorry. Guatemala right now has returned to having the highest mortality rate in Central America. There was a small point in time where we weren't. I think we were like maybe number 2, 3. We've also have the highest infant mortality rates and the lowest life expectancies. There's lots of malnutrition in Guatemala. This is more evident in the indigenous communities. There is a lot of malnutrition amongst children, amongst pregnant women. It's a cycle that continues. And it's a big problem in Santiago Atitlan as well. So you'll see that Concepcion will talk a little bit about that. So unfortunately, the major causes in Guatemala are still preventable causes, primarily from communicable disease. Hygiene is a very novel concept in many of these communities. They also live in dirt floor housing. There's a lot of poverty. There's a lot of wildlife around, living with the families. So it makes it very easy for disease to be transmitted. So the majority of the deaths in these rural communities in general are from diarrhea, pneumonia, other infectious diseases like tuberculosis, and malnutrition. So I'm going to be translating a little bit for Concepcion. So right now I'm just wanted to ask her what does healthcare look like in Guatemala? I'm going to be asking her if there's any medical coverage, and how does one access healthcare in Guatemala? Concepcion, buenas.
Buenas, doctora. Buenos días.
Quería que nos explicara un poco de lo que me estabas hablando ayer, de la cobertura de medicina de salud en Guatemala.
Muy bien.
Médico en Guatemala.
En Guatemala, de que la verdad no tenemos cobertura. No existe un seguro universal. El único que existe es el IX, significa Instituto Guatemalteca de Seguridad Social, que cubre los trabajadores de dependencia. Es toda aquella persona que no tenga un trabajo en relación de dependencia, no cuenta con ningún seguro médico. Su única alternativa son los hospitales públicos o pagar un servicio privado.
Okay, gracias. Un segundo para traducir. So what she's saying, in Guatemala, there is no universal health care coverage, nor is there any medical insurance that you could buy into. The only program that does exist is something called IGS. It's the Guatemalan Institution of Social Security, and it's something that specific workers can pay a monthly tax and buy into to get health coverage. However, I believe it's less than 5% of the population actually has this coverage. She also said that if you want to access any health care, you either have to go to one of the free government clinics or you pay a private facility to get care. Y Concepcion, ¿hay suficientes instituciones y centros de salud que son gratis para las comunidades?
Perdón, no escuché muy bien.
En las áreas, en las zonas a donde vives y trabajas en Sololá, quería saber si esas áreas hay suficiente clínicas de salud en los departamentos.
Creo que no es basta, no hay suficiente. Es por el sistema del Estado de que no inviertan más fondos, entonces es menos servicios que hay, más que las personas de las aldeas no tienen ese exceso de llegar a un clínico cuando tienen esa necesidad. No se escucha.
Sorry, I was muted. Just letting us know that access to care is very difficult. There are a few health centers in these more rural areas, as in the Department of Sololá, which is where our program is based and where Concepcion works. You'll learn a little bit more about Sololá as we go along, but this is a department of about 500,000 people, and there's only one hospital system, one national tertiary care facility that can actually accommodate a C-section or any kind of surgical procedure. So she was just highlighting the shortages of clinics, and then also the difficulty to access when you live very far and there isn't transportation. Okay, Nazanin. So this is a great slide just to kind of give you an idea of how much is lacking and what resources are really scarce in Guatemala, especially in regards to healthcare. So here it says that in Guatemala, there's 0.6 hospital beds per 1,000 people and about 3.5 doctors per 10,000 people. When you compare it with the US, it's pretty startling. It's pretty sad as well. So in the US, the numbers are more than 5 times the amount of doctors per 10,000 people than you have in Guatemala. This is definitely even probably much less in rural Guatemala, I would have to say. I know that as far as in our town in Santiago, where Concepcion works, there's one health facility with there's 4 medical doctors, and these 4 medical doctors are responsible for our population of about 55,000 people. However, they are only located in one small community clinic, which is centrally located off the main road. So if you live in any of the other rural areas a little further from town, accessing your only 4 doctors is pretty much almost impossible. You can go to the next one. Ellie, do you have anything to contribute? I see you shaking your head. You're muted.
I'm agreeing with you. But we can go to the next slide. I'm going to talk a little bit about maternal health disparity here. In Guatemala, the reality for indigenous women is they're much worse off in maternal health numbers than their Latina counterparts. In Guatemala, the national maternal mortality rate is 95 per 100,000 live births. And to put this in context, the US has a 17.4 death per 100 live births ratio. So the risk of women dying from a maternal related cause in a low income country is 120 times higher compared to a woman in a high income country. That's just to put it in context. And now within Guatemala, indigenous women are more than twice as likely to die during childbirth than their Latina counterparts. So the ratio for maternal mortality for indigenous women is 163 for 100,000 live births. And another thing to put in context here is that Guatemala is almost half of the population of Guatemala is indigenous. We have 23 languages or ethnicities. And in general, indigenous people face huge socioeconomic and health burden compared to mestizos or Ladinos. And another little factoid that we have here on this slide is that 77% of indigenous people make less than $4 a day, which is around, what, 30 quetzales or something like that. So it's not nearly enough to break the cycle of poverty.
I'm sorry, Nazanin, can you please? There you go.
There we go. Okay, that's what I was saying. And we can even move forward now to the next slide. Thank you. One more, one more slide, please. There we go. So let's see. Jess, were you going to talk about this one?
Yeah.
Okay.
So I think we felt it was important as a Guatemala team that it was important to really explain in our talk today, the barriers to healthcare for indigenous populations. Because these barriers really influence our programming on ground, and we've had to really adapt and change a lot of our programs to as we started to understand these barriers and how complex they are and how everything is related, you know. And it's been a really big challenge, especially now during COVID. Many of these barriers here have made any kind of intervention during the pandemic to continue to support women in our community has been a big challenge. And so today we're also going to talk a little bit about how we responded to that. So Ellie, Concepcion, and I are just going to talk a little bit about some of these barriers. here. Number one we have here is chronic poor health. You heard a little bit already about how access is difficult, and you'll learn about some other things that unfortunately keep these populations in this chronic poor health status. So rural indigenous populations, they're less likely to have access to adequate nutrition, and these are especially vulnerable to chronic malnutrition because of these consequential health problems. So 80% of children under 5 are chronically malnourished in Guatemala. I know that in our specific town alone in 2018 in Santiago, I was assisting with a family that had 2 children severely malnourished, and there was about 8 of them that had died that year in just our town of Santiago, which to me just seemed like a very high number, and it was very upsetting, especially when you're living in the mountains in a beautiful area with so much green and fresh food and produce. However, no education to really understand how to use all the food around you to have better nutrition and feed your family. So that's another cultural thing that we can also talk about later, that Concepcion will explain. So the lack of access to healthcare services is a really huge issue. There's many reasons that women don't access healthcare service. You'll continue to learn about that more. 70% of indigenous women living in rural Guatemala continue to deliver at home without receiving adequate prenatal care. This is because in this culture, women seek the care of a comadrona. Comadrona is a Mayan traditional birth attendant. They are leaders in their community for women. They are the voice of women in this community, especially in these indigenous rural communities in Guatemala. Women don't have the autonomy to have their own voice for cultural and religious reasons that are really deeply rooted to their culture. So the comadrona becomes the one that does the teaching and the caring, and they don't just deliver and care for women during pregnancy. They advise young girls when they get their first menses. Parents have a difficult time having these conversations, so they rely on the comadrona. This is why Saving Mothers in Guatemala has created the School of Power, and we work primarily with comadronas and training them to be community health workers and leaders in maternal health in their community. That way we are able to provide adequate prenatal care to such an amazing community that we live in. Language barriers, another big issue. And so there are about 28 dialects, I believe, of Mayan dialects. In our community, in our town, we predominantly speak Tzutujil. However, when you go to the healthcare facilities, they are predominantly Spanish speaking. Even if there is a nurse or a doctor that may be familiar with the native tongue, they will refuse to speak it because of many factors. Discrimination is an issue, as you see in number 3, that has been a part of this culture for many years. The community that we particularly live and work in is a community that just ended many years of civil war. I believe it ended in early '92. So they are still really recovering from it. This particular community on Lake Atitlan that we work in is very small, and most people have never left their town. They enjoy their culture. They enjoy teaching you about their culture. They're a very peaceful community. However, they're also very mistrusting of seeking healthcare because of the discrimination that they have faced all these years. Indigenous populations face discrimination in many ways. They are often evicted from ancestral lands by the government, which is very sad. Many also, when they fall into the judicial system, they are discriminated against, and they are definitely not given a fair trial. there are many other factors to discrimination. Women are discriminated against just for being women, and then an indigenous woman is discriminated against even more so in many of these facilities. Pregnancy is looked upon as shameful in this community. So a pregnant indigenous woman probably is one of the most more oppressed in these communities, if I have to give my observation and actually what I've noticed. I'm working for the past 10 years in Guatemala. I don't know if you have anything more to add there, Ellie, to this slide, or if we maybe we can ask Concepcion, because she always, I love the way she speaks about this in our videos. So it'd be nice to hear from her. Concepcion, me gustaría que hablas un poco más de la discriminación en los pueblos indígenas, más en relación con el Ministerio de Salud y lo que piensas en todo eso.
Sí, creo que la discriminación viene desde el Estado, porque así como dije de que el Estado o el Ministerio no invierten más por la salud en la población. Entonces, y la población es la mayoría, son indígenas. Entonces, no hay más insumos, no hay más personal. Y en donde hay igual, llegan gente indígenas, a veces no se atienden porque no son conocidos, no hablan en idioma maya, a veces dan atención solo porque tienen cuello, son conocidos. A veces personas que llevan regalitos al personal. Entonces, allí viene lo que es la discriminación por falta de la educación de personal indígena. A veces llegan así con no muy higiénico. Entonces, ahí entra en lo que es la discriminación.
Okay. So Concepcion is saying, as she had stated before, that the healthcare system doesn't really invest more in the indigenous health. There are many factors to why the reason for discrimination of the indigenous communities when they seek care. One of them, she said, is the language barrier. No one speaks the Mayan tongue, so that's a big barrier there. Hygiene, and many of these indigenous populations may not be so may not be so hygienic, and they get discriminated against that. For I remember Concepcion had told me that if their clothes is torn and they seem a bit less hygienic than the others, that they won't get care either, that the doctors just avoid even speaking to these patients seeking care. Ellie, remind me what other things she said. I know she was talking about
that it's very common for patients to arrive with a gift or maybe some money for a doctor in order to be seen faster.
Yes, that was impressive. Okay.
Yeah, and it's also like they give preference if you know the doctor personally, you're going to be given preference. A lot of times people are discriminated against about personal hygiene. So imagine, someone working all day with campesino.
I can't hear you, Ellie.
Okay, I was just talking about personal hygiene. They're discriminated against because of the way they smell, their clothes, their sweat, these kinds of things.
Which is very, very sad, because many of them they're farm workers. They're
exactly
in the coffee field. So if they have to go to the doctor between a certain time, they may be coming straight from work, and then that's, because of that one reason, they're not getting the care they need.
Right.
You can go to the next slide.
Okay, so We've already sort of talked about a lot of these things, but infrastructure and transportation are another big barrier to care. In Santiago, again, there's more than 50,000 people, maybe around 52,000 people, and there's only one health center which is not equipped for any life-saving surgery or surgery in general, like a cesarean. People that need C-sections are referred to the hospital in Solola, which is about 2 hours away by an ambulance ride on, bumpy roads. So poor road quality, lack of this transportation. And then the other thing is, even if you get an ambulance ride, you might be charged for the gasoline. The health center might charge you for that ride. And
well, the health center won't leave if you don't have the money to pay for the gas. Many times,
so
no one wants
you're charged an additional fee. A lot of people don't have the money for that. And just in general, infrastructure around health system dynamics, there's not enough people to care for the population. Jess already talked about lack of education, but there is a lot of discrimination against women, and therefore lack of education. Women aren't sent to school. Not having any sort of sense of health literacy makes you unable to decide for yourself whether or not you're needing medical care. So you may not be able to make the decision about going to the doctor. Your husband might say you can't go to the doctor. That happens a lot with us. We often go to the patient's home to talk to the husband. This leads right into the culture. The traditional gender roles here are very, very strong. And what we talk about in Spanish as machismo or chauvinism is very, very prevalent in Guatemala in general, but even more so in indigenous communities. And the reason we work with comadronas at Saving Mothers is because that's who the women trust to see them through their pregnancies and births. We can continue here. Next slide, please. These are photos back when we could touch each other and give hugs.
So over here, we'll give a little background. So this is on the left is a picture of Ellie when she first met our team. It was part of, I guess, her interview process. And it was the first time she met them. I had connected them on ground. That's Concepcion on the right. And then I believe that's Josefa on the left. So about an hour after she met them, she was still in her interviewing process. She messages me that she loves the job. She wants the job. So I'm really glad she had this great experience. And they were at an event to promote breastfeeding. Is that correct? It's like Day of Lactation in the community?
Yeah, National Breastfeeding Day.
There you go. Yeah. With the local church, that was great. And then on the right here, I don't know what I'm doing, but we're having a birthing simulation training is what it looks like. I think that's in the rural town of Camotan. So
yeah,
also goes and travels around Guatemala with our team, and we bring our educators and our local ladies everywhere we go, and we have them lead trainings with other birth attendants in different communities. And we also do kind of just classes to pregnant women to understand warning signs of pregnancy, as well as warning signs in your newborn. And so we have a lot of fun traveling Guatemala together. All right, you can go to the next one. Daniel got great pictures.
Okay, so to give a little bit more background, Guatemala has a high teen pregnancy rate. In 2019, there were 66,000 teen pregnancies. And in just so far in 2020, from January to now, the Ministry of Health has reported almost 2,000 pregnancies, specifically in girls between 10 to 14 years old. This age range it's been high for many, many years. In 2014, there were more than 5,000. So it is going down, but it's still alarming. Child marriage and rape and violence against girls is a big problem here. This stat here from 2014 states that in 25 of the cases, the offender, the rapist, was the father, uncle, grandparent. And of course, these adolescent pregnancies are much more common among uneducated or poor Indigenous women. A big reason for, sorry?
It's interesting. I mean, a big contribution to that as well was that only in 2018 did Guatemala finally change the legal age of marriage. It used to be, I believe, 14, and they changed it to 18. It was the last country in the world to change the legal age of marriage to 18. So, and only recently are they actually having hearings in court cases to address complaints of women of domestic violence or any kind of physical or sexual abuse. Something that's just started happening. It's still very slow. It's not like here and where we can get that support much quicker, but I have been seeing some changes happening, at least in our towns.
Yeah, it's in general in Guatemala. It's normal for you to be forced to marry your rapist, or if you're pregnant, if you get pregnant and you're a young woman.
I don't like the word rapist. Let's just say offender right now.
Offender. If you get pregnant, if you are impregnated, you are oftentimes required to then get married.
Yeah, or you bring shame to your family.
Right. So this goes right into religion. The majority of people here are either Catholic or evangelical. And like Jess already mentioned this, the comadrona does a lot of the work that, in other countries, maybe a mom would do or a dad would do, of educating around sex or menstrual cycles or any of these things. And this is only compounded because since a lot of the offenders are within the family, it becomes even more shameful to discuss these topics. Yeah, we can move on in the interest of time.
So I'm just going to be very quick. Department of Sololá in the Western Highlands of Guatemala is where we're at. Right now, we actually just got the most recent number is 500,000 plus people. Another slide has the exact number. And so this place has over 75% of births in this area, this region, occur in the home. They do not occur at an institution, a hospital, a clinic. And so most of them are also attended by the comadronas, which we had spoken about before. So it places these women at risk. This is why we are working with comadronas to not necessarily change their culture or change what they do, but empower them and educate them to have the proper tools to safely continue to practice what they call their dawn, which is their calling. Because we all know that home births can result in hemorrhage, infection, and preeclampsia, and other related complications that without a skilled birth attendant can really be fatal to mom and baby. You can go next. So Saving Mothers created the School of Power in 2014. Just a little bit about the school is we train comadronas, birth attendants, and we also have opened up to training local auxiliary nurses that are working with pregnant women in the communities. And we teach basic prenatal and obstetric care. We focus on preventative measures and education. And we've been able to really work with our ministry partners in providing care for women. Since 2014, we've had about, I think it's 7 classes already, correct, Ellie? 7 graduating classes of midwives. We recruit women from all over the department and all over the lake. We have women from different Mayan communities. We have Quiché speakers, we have Tutujil speakers. And what's beautiful is that the whole curriculum is taught by our educators, by local women, and it's taught in their native language. As you can see right here, there's just some pictures of different, I guess, training sessions that they've received. Our women get great support from a lot of our partners. They're always participating in different certification programs. They love to learn, and our educators are now running our programs on the ground. This is just more pictures. The one on the right is our first School of Power in 2014. So that was probably one of the most amazing experiences for me in my life, to be able to finally put into action a dream and a project that I had been working on for so many years. And to do it with these women was really great. And then now to have them here continuing the program is even greater. Concepcion, ¿recuerdas ese día de la foto?
Sí. Sí.
Muchos recuerdos.
Many memories is what she's saying.
Yeah.
Right,
And the
now.
picture on the left is her giving me a flu shot. That was recently.
Oh my God.
Yeah.
Saving Mothers protects everyone, and so we made sure all of our ladies had flu shots and their vaccines too, so we could also protect our moms.
Yeah.
Okay, and you can go to the next slide. That's Josefa. Josefa is one of our lead educators and one of our first graduates in 2014. She was a health facilitator in her community when we met her. And she is also in her second year of nursing school at the university, and we are very proud of her. Oh, Ellie, you want to tell us about the situation, COVID in Guatemala?
Yes, now we've reached the meat of the webinar. Yeah, so right now, this is yesterday's data. I'm guessing there's more cases today, but we have 41,000 cases already in Guatemala. There are almost 12,000 active cases. And, you know, these numbers, I'm always questioning the accuracy, right? These are reported cases. These are, you know, people that have gotten tests. So we imagine that there are many more. Right now we've had 1,500 or so deaths, and another MPH that I read his articles, he is saying that if we continue with all the norms, all the precautions, we can expect 3,000 deaths by October. If we were going to eliminate all the precautions, in Guatemala right now, it's mandatory to wear a mask. For example, there's no public transportation running, nothing is open. We have curfew every weekend and every day. Everyone has to be at home by 6. So all these precautions are helping. He says that if we were to, you know, release and go back to normal, we could expect 15,000 deaths by October. His name is Edwin Asturias. He's in charge of the COVID. He's like the Fauci of Guatemala. But anyway, so we're doing okay. You know, it could be way worse, but it's definitely not great. And then we can move to the next slide. This is specific about Santiago. This was released a few days ago. Again, everything is sort of like taken with a grain of salt, because for a while there were no tests. Now we have tests again. So right now there are 52 recovered people and, you know, 68 positive test results. And they say there's only 9 active cases. I'm always going off of information that I get directly from Concepcion or other health workers that give me the lowdown of how their shift went. That's the best way for me to be up to date. This is data published by the mayor's office, so the municipality puts this out. And I'm glad they're doing it, but again, I'm always sort of wondering.
From our experience working, collecting data is very fragmented. They don't have a very good system of collecting data. We have tried to offer our help in organizing their data. However, what we learned as we collect our data and try to compare with ministry data is they have a woman who receives anything from text or WhatsApp messages or emails or pictures of notes that other health providers write down with patient information. And she collects all these different pieces and put it together, and that's how they report these types of numbers. So we definitely think that it gives us an idea, but the accuracy we question a lot. We do go by what we get from our community and what is asked for us. We have a very close relationship to the community. We can go to the next slide too, Nazanin. Saving Mothers has a really close relationship to the community. We've built a lot of trust in the community. We have great partners and we work alongside the ministry. And so during COVID, we started to learn that many women were so afraid to seek care that they stopped going into the healthcare centers altogether. This is another reason is they didn't trust the healthcare centers to be able to protect them from getting COVID. And they knew COVID symptoms were showing up at the healthcare centers. Another thing that started to happen is women in fear of seeking the healthcare centers just started to go to a comadrona. Here in Santiago, just a little background, we probably have higher rates of institution births in the healthcare center than other areas, but that's because we've worked a lot with the local ministry clinic for the past 10 years and have really helped them kind of create a more community-friendly clinic and services. And we really feel that our collaboration together has been able to kind of, I guess, bridge that gap between this the health clinic and the traditional medical aspects that the community really seeks more often. So now all of a sudden we're getting elder midwives calling our younger midwives and our educators and saying women are just showing up at our house, we're scared, they're pregnant, they don't want to go get care, they're not my patients, what do I do? And so we decided to come together and start designing a protocol so that we could address all these concerns. And so that's how our COVID-19 protocol started. As you can see, the protocol includes screening for COVID, signs and symptoms. That's done 24 hours in advance. We have everyone calling and doing telephone triaging. And that's when we can also take opportunity to start our education to the home and screen for symptoms, and also let the woman know what to expect when we show up the next day in a mask and in our uniforms. The community was also very afraid at this point in time when we created the protocol, because the ministry workers were showing up at people's houses in full hazmat suits, and it was creating a lot of fear and panic in the community. And so we realized that we needed to let people know that we are going to come over with a mask and maybe some PPE, some protective personal equipment. But we found that letting them know ahead of time why we were doing it and that we were going to be coming really did help us kind of reduce that fear and panic, and and open up, and they were able to open up their homes to us. The protocol is also geared to really talk about hygiene and sanitation, proper protective use of protective personal equipment such as masks. We know that many people are having a hard time conceptualizing really what the purpose of the mask is and how to use the mask. So we also did a lot of, it's a modified workflow that reduces direct contact as much as we can and protects our midwives and our patients, but we're still able to provide the care. We really started all of this with the focus groups, like I was telling you, the elders in the community were seeking us. So we hosted focus groups and also took the opportunity to give them supplies and educate them on supplies and how they could protect themselves. And we got a lot of great feedback during those sessions. And then we were able to design the protocol and begin our training and implementation. So right now we identified 8 of our educators and we did a lot of training. Ellie and Concepcion were really, really working hard the past couple months. We realized that, just a group training or a couple of trainings weren't enough, that these concepts were also very new to our ladies, even though they had a higher level of education than maybe some of their other comadrona colleagues. And so we really started doing one-on-one simulation training and individual training, and we had them kind of just keep working with us and their leaders until they felt comfortable implementing the protocols. And it was great. We used infographic, pictorial, I guess, workflow to assist and facilitate the training, which was designed by 2 amazing medical students that I have that I am blessed to work with at FIU. And so they really were able to put together this really long, comprehensive protocol into a 2-page pictorial guide, which I thought was very impressive. You can go to the next slide. So we've been now implementing the protocol for maybe about a couple of weeks, and we're starting to learn. But I'm going to let Eleanor and Concepcion maybe talk more about that because they're the ones doing all the implementation on ground.
Sure. So again, like Jess said, a lot of what we did is train around PPE use. That was like the new topic to introduce to the ladies. And this week we rolled out our protocol. We started it. So we've started seeing women at home. And, you know, the comadronas, the elder comadronas have continued to see women at home. But yeah, this is basically what we've done. The next slide has a picture of what we called our COVID kits. This is like a little bag that has an N95 and gloves and hand sanitizer and everything the comadrona needs to safely see a patient. And we've created it so that she doesn't see more than 3 patients in a given day. And everything is in plastic and washable, and
it's broken down into three sessions, like what you do the day before your visit. And so that's when they have to make sure they have the proper clothing. We have specific uniforms that we wear and we wash and we keep separated from the rest of our clothing. They have to make sure all their supplies are clean. We have provided every one of our educators and women that undergo our training with their own disinfectant, Clorox, so they could wipe down equipment and things at the end of the day. They have to also clean equipment the day before visit. During visit, they also have a part of the protocol is cleaning during the visit right after use with alcohol. So I mean, it's been a lot of work for them, and I'm really proud to see them finally comfortable. At first, the women were very afraid to put themselves out and at risk by doing home visits when they were seeing so many others in their communities coming down with COVID. We actually lost one of our members in our community of Saving Mothers in Guatemala to COVID. One of our first graduates and an elder midwife of the community passed away when she got sick with COVID. So this also instilled, a lot more fear amongst our group and our ladies. But with the training and education and all of the conversations that we had, and we allowed them to express how they felt and worked with them, they all now feel comfortable and they have started seeing patients. And these patients that they are seeing are the patients that the government has not been able to reach or see due to COVID changes in their system and their infrastructure. So we are working and assisting the government in their outreach work in the communities and providing prenatal care. You can go to the next one. So there's some questions that we had you guys send ahead of time, and Concepcion and Ellie prepared answers. So I'll let them speak, and Ellie, you can translate for Concepcion. And then hopefully if we have any room for any more questions, you can also type any questions you have in the chat box, and I'm sure Nazanin can bring them up.
Entonces, para responder la primera pregunta, ¿cuál ha sido la respuesta del público a la enfermedad COVID-19? Es el número 24.
She was nervous, so we had her practice her answers and the questions yesterday.
De esa pregunta, la respuesta es de que hay muchos miedos, estrés, y bueno, los grupos están divididos en dos. Hay un grupo de que sí cree en el virus, tienen mucho miedo, Hay otro grupo de que no creen, se burlan de los otros. Y también de que muchas personas están practicando ya de consumir plantas medicinales, defensas. Yo miro en mi comunidad de que la mayoría de que sí están ya valorando lo que es el valor de la planta, todos los días toman, entonces para mí ya es un cambio. Y también hay cosas muy positivas también que nos está dando este virus. Están practicando lo que es la higiene, lavado de mano, están bañando ya muy seguidos, consumiendo cosas así, no de la calle, sino que están preparando en sus casas, comiendo muchas hierbas. Entonces también hay cosas positivas y negativas que nos trae esta enfermedad.
Voy a traducir.
Oh my God.
I'm going to translate. So we answered some of these questions yesterday, but she added a bunch, so I'm going to just do my best here. But people are afraid and they're stressed and they're in their homes and they're divided in two groups. One group believes in science and virus and are taking precautions, and there's another group, specifically members of a
Just translate word for word.
that don't believe and that make fun of the others. She also talked about the changes in behavior that people are doing now. People are consuming a lot more medicinal plants, herbs and produce instead of things from a store. These are some of the positive changes that she's seeing, that people are valuing the natural instead of what they were doing before, eating healthier, and that's something positive that's happened.
She also said that a positive change is that it has improved hygiene in her community. She said people are washing hands more, people are bathing more, and this is a positive change that she's seen.
Right. Seguimos con la segunda pregunta.
Cambio de experiencia de embarazadas. Por mí, es de igual manera también. Hay mucho miedo. Ya no están llegando a su control prenatal en los servicios de salud. Tienen miedo al personal. Piensen en contagiarse al momento de que ellas llegan. Las comadronas ya tienen muchas demandas. Incluso nuestras comadronas de Povers están atendiendo partos de emergencia. Entonces, es una experiencia que estamos pasando, pues, que son nuevas. Y igual manera están consumiendo muchas hierbas, se están alimentando naturalmente. Ya no compran así comidas en las calles como antes.
Yeah. So similar to the last response, people are leaning more towards the natural. They're not eating as much junk food from the street, and it's changed significantly because people are afraid of going to the health center. People are returning to the natural. They're looking for ways to not go to the health center. On the other hand, there aren't as many options for pregnant women to be out in the streets, and that's a little bit sad. They're in their homes. There aren't as many options to do exercise, for example. And for some pregnant women, there's not enough food or work, so there are some issues with malnutrition.
Seguimos con la otra. Bueno, dice que cómo van la salubrista, personal de salud o comadronas ahora, dice. Bueno, igual en los puestos o en los centros de salud, pacientes así normales tienen mucho miedo. Solo están llegando personas que sí de emergencia necesitan atención médica. Entonces, Igual también mucho miedo. Al llegar un caso allá, nosotros como personal salubrista demoramos mucho tiempo porque solo habemos el grupo no específico para COVID, sino que es general. Atendemos pacientes en general y cuando hay casos empezamos a poner nuestra protección. Lleva mucho tiempo, la gente se molesta, piense que no estamos atendiendo bien, pero no es así, es por el mismo sistema. Ahora, en caso de nosotras las comadronas, yo siento que una mujer empoderada, ¿verdad? Por Salvando Madre, porque tenemos esta capacitación. Yo miro de que mis compañeros de la primera promoción, de que antes no tenían esa experiencia, pero ahora ya son mujeres empoderadas, de que sí están brindando su servicio, aunque al principio con mucho miedo, pero agradezco mucho a la organización de que sí nos están animando ahora. Ya sentimos personas con valor, ¿verdad? Que estamos realizando este trabajo. Es un cambio del Ministerio de Salvando Madre. Y también de que nuestra gente de la comunidad no nos tienen mucho miedo porque no estamos metidos en lo que es el centro o puesto de salud. Somos un grupo capacitados y estamos muy aparte con el ministerio. Entonces nos tienen más confianza.
Sí, Concepción, tienes que dejar un segundo para que traducimos porque si no, no podemos decir todas las palabras bonitas. I'm sorry, everyone. She's so passionate. I love seeing this. I mean, this is a woman who would never speak before either. So I'm really, she was just saying from the medical staff perspective, being that she is medical staff, she says that patients get very fed up and don't understand why they have to wait for the medical personnel to put on their gowns and properly don and doff, which means properly put on the PPE and properly remove the PPE. It does increase visit time, and so they notice that the community gets even frustrated about that. And then she also went on to say, as far as the comadronas, she feels herself an empowered woman working with Saving Mothers and with this protocol, and that she is very happy to see her colleagues that were also graduates from the first class being empowered to go work in the community and do something that a few weeks ago they were actually afraid to participate in. And then I stopped her.
Another thing is that the community doesn't fear the comadrona as much as, say, a medical worker. There's been a lot of fear, just to give a little background, there's been a lot of fear around medical personnel with the idea that they have COVID and they're going to give you COVID. So the comadrona is much more trustworthy. And so people are responding well to our effort because they don't associate us so much with the health center, even though we do work with the health center. But that's pretty wonderful as well.
Gracias, Concepcion.
Gracias.
We're just right on
Gracias
time.
a la doctora.
We're right on time, and I see we got a question from Natalia. Do we have a minute, Nazanin, or do we need to go?
Yes, go for it.
Okay. So Ellie, this is the question we got. I noted in horror the challenges with sexual abuse of minors in particular. Is Saving Mothers collaborating with grassroots organizations dealing with sexual crimes, given that most of your patients are victims of sexual abuse? It was mentioned that many patients are not attended to by medical staff due to the clinics being scornful due to hygiene. Are there no legal implications for denying medical care to a person and more so a pregnant patient? Okay, two good questions. There are no legal ramifications for anything in Guatemala at this point. From what I have seen, we are very lucky to work in a small rural town where there's maybe lots of petty theft, but as far as feeling unsafe in other ways as a foreigner, definitely do not feel unsafe. Now, if I was a 8-year-old local indigenous girl, I probably would feel very unsafe, but they are not even aware of a lot of the risk and the lack of protection. So we do not necessarily work directly with grassroots organizations. Also, most of our women aren't sexually abused, but we do come across many women who are, and people do seek us out and our ladies whenever there is any sort of a crisis, whether it's a birth complication or even something so personal as abuse in the home. We do have places that we refer. We work with the families to help connect them to the services they need. But a lot of times our work is just really helping the family even cope and understand and accept that this happened and not shun the young girl. We work a lot with trying to get them to see the importance of emotionally supporting her. And then all the other legal aspects kind of really just, it's very complicated. And the mother-in-law, the father, they're the ones who are going to make the decision whether it's appropriate, demandar, which means make an official legal complaint. And that doesn't always happen. So
I think the tendency is to not report for fear
that
of
everybody in the
making
village is going to know.
Yeah, for fear of making more waves, whether that be, gossip and so forth, but also just more danger towards that person. And that's a huge generalization. I mean, we can't say that for every case, of course, but a lot of the time that's what the experience of it is.
Technically, they're supposed to provide everybody medical care, but it doesn't happen. And there's just no services or no departments or anything that's kind of overseeing. There's no system of checking one another and making sure everybody's kind of complying with written law. I mean, Guatemala has a lot of really beautiful written law, especially around like even reproductive health literacy in schools, but nothing is implemented, nothing is enforced, and no one's overseeing to make sure that it's implemented. So it's very complicated. And I see that translates over into the legal aspect of things. Police aren't trusted either. You can easily buy off of police. If you have money, you can pay them and they most likely will let you go. So, I mean, it's very complicated. And so we work within these complex systems. We also really try to focus not to promote completely going against systems or fighting or rebellion or conflict, and we just try to support and work around some of these systems because we want to be able to help these women continue to work around the challenges they will continue to face in the communities they live in. Okay. Oh, thank you so much, everyone, for attending, and please support us as much as you can. Donate to support our programs. You can donate on our website, stay in touch, spread the word, share our posts. Anything you can is welcomed and appreciated. Thank you so much for being here. Eli, Concepcion.
Adiós, muchas gracias.